So today I'm gonna intro Jim Dietsche, who's the CFO at Bellin Health organization. I've known Jim actually I was thinking about it, Jim, I want to say 17 years, and that goes back to 2003. We were in the Chamber of Commerce CFO roundtable together for probably 10 or 12 years. And go ahead, Michelle.
Not here, you don't see me.
Jim has always been a true professional. He came from Whipfly prior to that, but and I'm going to age myself here, but like E.F. Hutton, when Jim talked at our CFO roundtables, people listened. And it's just because he's a really smart guy and he's eloquent, and we always enjoyed hearing his perspective on a problem or opportunity that came up in the roundtable. The interesting thing I remember about Jim is he's also quite an athlete. He's a marathoner, and some of his workouts, like, I can't even imagine doing them, quite honestly. And it was always interesting to hear what he had done at 7:30 before we even started the meeting. Now, I ran like 12 miles or something, so it was pretty cool. But Jim was actually at the bombing at the Boston Marathon in 2013. And I think we spent an entire meeting after that happened about what happened and how he made it through with his family. It was fascinating and better than any movie you could see. But anyway, Jim, welcome to FEI Northeastern Wisconsin, and we look forward to your presentation.
Thank you, John, for that great introduction, and Michelle, thank you for clapping for me. This is it's a different setting we're in right now, and thank you, John, for the wonderful introduction. I finally watched the movie Patriots Day about a month ago. It took me that long to watch that movie, and there definitely was a lot of emotion when I watched that movie. It wasn't worrying about myself, it was worrying about my family who was there supporting me. So today I'm going to try to really talk a lot about kind of what's going on. When I first was asked to do this was 6 months ago, and I never imagined in my wildest dreams that I'd be sitting here in the middle of the pandemic, which is ultimately, we are the state that is very challenged by this. And I'm going to share a lot of data with you, and I think it's important for you to understand. I'm going to try to give you how we see this, and ultimately likely where this is heading, and give you some hope as the vaccine starts coming out. I'll also talk a little bit about how the guiding principles, I think that hopefully it are foundational for you and your organization, and how we've really maintained our strength through this challenging time. So just very briefly about who we are. We cover about 12 counties. While we're a sizable organization in terms of revenue and assets, we're not that big. Actually, we're one of the smaller health systems in our state. When you look at integrated delivery systems in the state of Wisconsin, we are the only locally based integrated healthcare system in our community. And what that means is our governance is here. All of the decision making is in our community for the benefit of the 12 counties we serve. We have obviously the hospital, but we're really, hospitals to us are a place for taking care of somebody and getting them out and back into the world that they want to be in, and obviously trying to do that at the lowest price. So that there's a flagship component to that, but we have services across the region. We have mental health. We have a small hospital in the north in Oconto at a surgery center in Marinette. And when I say integrated, we employ the majority of the providers that provide services through Bellin. We do have independent physicians that do work as well, but we're very much integrated. We have a college, and we're very thankful for that right now, because a lot of the students are also actually working as well, and that's been a godsend during this time. And then we have lots of partnerships with other health systems, as well as with physicians across our region. This is just our footprint to just give you an idea of, and then also obviously all the many locations. This slide is dated, and I debated it on changing it, and I'm like, nah, forget it. It doesn't matter. It says we're on the brink of a major outbreak. The reality is we're here. You know, the truth is we have community spread of this illness, and we call it an infection, and I'll show you the data in a minute. So, and we really crash through records almost literally every day. Why is it going on? And we just listed a few things here. I think one thing that you don't see on there is employers. We didn't list employers. In the beginning, that's what it was. The positivity rate, there were outbreaks in different industries in our community. And the reality is employers, I think, have done a pretty remarkable job now of really maintaining the spread within their organizations. And I credit you for that. You've really taken this to heart and put together a lot of practices. But the reality is spread is happening, and now it's gotten to such a level that you can't contain it. You have a hard time containing it, and that's where we're at. So I'll show you the problem with that. You know, so yes, there are outbreaks, and you know what's really happened is, you know, a lot of outbreaks that occur with one individual and multiple individuals have spread, and then it hits senior living facilities and skilled nursing facilities and all of that, and now we've led to significantly higher hospitalizations. So what data do we look at? And I think I've given you all the sources in the slides. I know it's really small. You can look at that after, but you can go out for almost every piece of data that I'm going to show you today. You can look at yourself. We try to put together all of the stuff together so that we paint a picture. So really the simplest dashboard is something that the Wisconsin Hospital Association put together and stood this up. This never existed before. And I think what's really important for you to take away from this is a lot of this data is populated by the individual healthcare systems. And so it isn't the state that's populating the data, it's us. And it comes from our internal databases, and it goes through an electronic process, and every day this is updated between 3 and 4 in the afternoon, and actually now most of the media has picked up on it, and that's where they get their data from. So this is very helpful to us, and it's helpful for spreading information. There is data that is pulled from the Department of Health and Human Services, mainly on the testing, and I'll get into that in a little bit more. So this is the statewide, and I circled that for you. And obviously then you kind of get into more data that's more detailed on hospitalizations, which obviously we're very much paying attention to every day. Now the state hits a new record in terms of highs. I took this screenshot 2 days ago. I really wanted to try to keep the data current for the attendees. But you can see on the right-hand side on the top graph, I mean, we're at an all-time high for hospitalizations. And we really thought in the beginning, when the Milwaukee area really got hit hard, we thought that was bad. And now look at it. And I'll talk about the implications of that. On the bottom left is that positivity rate and the amount of testing that's going on. And then ultimately on the bottom right is deaths. So to drill this down, you can actually look at this by, these are regions. It's the HERC region, Healthcare Emergency Readiness Coalition, and you can break this down by region. So the first slide that I showed you was the state, on the entirety of the state, and you can break this down by region. So for those of you that are watching from the Fox Valley, there is a different HERC region for the Fox Valley, so forgive me, I chose Bellin's area because this is primarily the region we serve in addition to some of the counties in the Upper Peninsula of Michigan. And that we closely look at this data every day. And we also have been very much partnering with the other health systems in our community. We share hospitalizations every day. I get a text message of how many hospitalizations are at the 4 hospitals in Green Bay. And that's very, very important to understand as we plan, because what I don't think people realize is we're built to take care of everybody. All the hospitals are here to take care of everybody. If we just take care of COVID patients, and that's 250 if we get there, we are really not benefiting the other 600,000 people. Actually, it's about 650,000 people that live in our region that need health care. And that's really, really important to understand. So we're really trying to manage our way through this. So I want to get down into a little bit more in the weeds. What you can see on the bottom left-hand chart is that positivity rate, which is really that dark blue. And you can see what's happened. It's literally just exploded in terms of positivity rate. And I'll drill that down to Green Bay. And you can see on the top left, obviously the number of cases. And again, obviously you're going to set a new record in total, but you have to look at that daily rate. And it doesn't take a rocket scientist to look at the right-hand side of that graph and see how high that is. And then you see the hospitalization rate on the upper right. And there are 10 hospitals in the HERC region. And I'll talk about the Green Bay hospitals in just a minute, but you can see we're basically at a peak right now. And I'm going to, again, get into why that is happening. What you can expect to see is when the positivity rate spikes, about 7 days later, you get hospitalizations, and that's exactly what's happening. And unfortunately, those hospitalizations today, 1 in 3 that's over 70 ends up in death. And that's not good. That's very uncommon to have that kind of rate of death in hospitals. Doesn't matter which hospital it is, that does not occur in hospitals, and that's very alarming. So I want to drill down a little bit to people always talk about, well, is the data right? And I will tell you this data is right because we assemble it ourselves. So this is the community testing. And when I say by community testing, these are the 3 health systems in Green Bay that share this data unequivocally, and we look at this every day. So this is a rolling 14-day average, because you have to understand there's less testing on weekends, right? That happens. The other thing is you have to understand the state database also includes community testing that's done by others, including the National Guard that is happening, and now the federal government has set up a community testing site at UWGB. And that does not flow through this chart that I'm showing you. This is the 3 health systems that report this data out. And I know it's 100% accurate. I'm very confident in that data. So this data points we've been tracking since the beginning. And every data point on here is 14 days, because it takes out the noise of a holiday, it takes out the noise of a weekend, and you're averaging 14 data points in one measurement point. And you can see what's happened to the positivity rate over time. When that and it basically has not changed. We don't test as much because there's more testing that's available, but even when the testing that we have done, it still shows you how high that positivity rate is. So here is how many tests we're doing as the 3 healthcare systems in our community. And as I said, we aren't testing as much. And again, this is every data point has 14 days. And you can see over the last couple of weeks, it has slowed a little bit as other testing sites have come up. The fact of the matter is we look at our own data because we know that is likely the most accurate, and we track this obviously in real time, and that helps inform us what's likely going to happen in the hospital setting, which I'll show you in just a minute. This is an ugly snapshot, but I think it gives you a picture in time at the national level. Obviously, red is not good. And what you see is the infection level on a 7-day average per 100,000 people. So on the left-hand side, you see what the different risk levels are, and unfortunately, you don't see any green there anymore. And obviously, red is the highest level. And you can see what's happened over time. So yes, Wisconsin was a hot spot and has continued to be a hot spot. The unfortunate thing is the red just keeps getting redder, for lack of a better word. So when you look at Wisconsin and that infection rate, basically doubling from October till now, it just keeps going up. And then we just showed you Brown County as an example. And then nationally, we're not immune to this. So while we were the darling of the attention by the New York Times for a while, the reality is the nation is quickly catching up. We were just there first. I think this is a really important slide. I wish we didn't have as many numbers on here, to be honest with you, but this is literally the detail. So we look at positivity rate by age, and then we look at what happens in hospitalizations. And the top part is the Wisconsin population, and you can look at the breakdown of the demographics by age, the infections by age, the hospitalizations by age, and death by age. And it's important to understand that. But it's also important to know, and I'll show you in just a second, the positivity rate by age is no different than based off of the population. So in other words, if 20% of the population is 20 and under, 20% of that population has a positivity rate. There's no difference in age group. We look at that all the time, and I think that's important to understand. So it's not just 70-year-olds that have the high positivity rate. It's not 20-year-olds. It's everybody, and you'll see that in just a minute. What I do think is important to understand is 1 in 3 people 70 and older end up in the hospital with this. And then 1 in 3 people that are in the hospital that are over 70 end up dying. If that's your mother or father or grandparent, and they die because they can't breathe, is that how you want that to happen? Because that's literally what is happening. And we're no different. So I gave you the state averages. Bellin and a Bellin service area is exactly the same way. And it's going to keep happening. We've had 7 deaths in 2 days at Bellin. 7. We don't have 7 in a month sometimes. People don't come to the hospital to die. They come to the hospital to get well. That's the reality. This is the trend by age group. Again, no single age demographic is immune to this. So if a 20-year-old gets it or a 30-year-old gets it, and they pass it on to their mother or father, or they go to their work, and they pass it on, and they pass it on, and it ends up in a 70-year-old or an 80-year-old, this is what happens. We just updated this slide yesterday, and that rate just keeps going up. I was hoping you saw in the red, the 50 to 69, the green and the red, the 70s or the over 70, I was very hopeful to see that number keep trending down, because that tells us what's going to happen the following 2 weeks. And it's going back up again. And here's the deaths. So, it's troubling. It took us 7 months for the state of Wisconsin to get to 100,000 positive cases. It took 5 weeks to get to the next 100,000 cases, and it took less than 3 weeks to get to the next 100,000. We're over 300,000 positive in the state of Wisconsin. And as a result of that, more people are dying. And what I'm really, really worried about is when a lot of people are focused on this, then people say, I don't know if it's safe to go to a hospital right now, or I can delay my care. And that's just going to lead to worse outcomes. We learned that when we went through the delay and the stoppage of cases, time-sensitive procedures, cancer case identification delays because screenings weren't happening. We've learned a lot of valuable lessons. We do not want to stop taking care of everybody. And that doesn't go just for Bellin, it goes for every healthcare system in this state. We have a high-quality healthcare delivery system in the state of Wisconsin, regardless of who that system is. And it's potentially being compromised right now. And that's going to impact employers. It's going to impact everybody. And I'm very, very worried about that. So I want to share with you kind of just an illustration. The lady on the right, Jessie Schomburg, every day I get an email from Jessie. We all do, telling us what happened the day before. And it's very, very sobering right now. The number of hospitalizations we have in people in our facility, the number of admissions, the number of discharges, and the number of deaths. And I see the names. Our healthcare workers are unbelievably resilient. I actually ran with somebody this morning, appropriately ran with somebody, accidentally, who's an ICU nurse, actually at Aurora Bay Care. She's a NICU ICU nurse. And she told me today she's working in their regular ICU because some of their staff needs a break. And she's a neonatal intensive care nurse. These folks wake up every day because they do unbelievable work at the front lines. And while they're trained for emergency medicine, they're not trained to handle all that's going on right now, mentally and physically. We get 8 admissions a day and 9 discharges. 6 today, 13 discharges. It's overwhelming every day. It's not people staying in our hospital for 15 days or 40 days or whatever. They come and then they get discharged or they pass away. And the next day, they do it all over again. That is our team. And what I want to share with you right now is a poem by one of our RN ICU nurses. Her name is Jessica Landry. And I just want you to think about what she does every day in her words.
A world of emotions, hesitations, moods, expectations, second guesses, double looks, triple checks, fear, confidence, doubt, experience. Our purpose shifts. A new war, a pandemic. Raise your hand, let's go. Suit up, wash your hands, put tubes in, pull tubes out. It's gonna be okay. You can do this. 2 more gone today. Next in line, which finish will they cross? Faces turning blue, life fading from their eyes. Breathe in, breathe out, slowly, deeply. You look better today. Stay positive. Anxiety ensues, panic attacks. Don't let it get to you. More medications. Much better. Breathe in, breathe out. We pivot. Coworkers become comrades. We carry a hefty label. We overlap your care, looping again and again, advocating, assessing, communicating, monitoring, watching trends, catching declines. Don't let those drips go dry. Steps become escalators, high flow, CPAP, ventilator, and reverse, hopefully. Can you hear me? Squeeze my hand. Wake up, go to sleep, we'll try tomorrow again. Stories fill our heads but can't cross our lips. Our souls get bruised from the ones we can't fix. Breathe in, breathe out. We echo to ourselves. Breathe in, breathe out. We got you. We got this. Breathe in, breathe out.
And so it goes every day. I mean, what she said is exactly what's happening. Overlapping care. You heard her say it. We're not coworkers, we're comrades. They're trained to fix people, and they can't, and their souls are bruised. And it's happening multiple times. I'm so thankful that we have people like that. We need people like that. If there's anything you can do, thank them, reach out to them, support them. They're not used to this. And it's happening every day in every hospital in our state and nation. All right. So we've put together a model of what's happening with hospitalizations, and we understand, I'm sharing this slide with you, but it's a point in time slide. It could change tomorrow. This is predicting what we think the hospitalizations are going to be in our region, not at Bellin, but in our region. The purple line that's across is our capacity. And for every bed that we add to help COVID is a bed that's less available for someone with other acute needs. Yeah, they've opened up an alternate care facility down in Milwaukee. Sure. You want to send your loved one down there? You know, we have to face what is going on. Again, right now we're predicting that we're not even at the high yet. The black line is what we've tracked, and the model works. We've validated the model. Now, obviously, it can track differently. You know, I think about this like tracking a forecast. I wish it was just tracking a forecast. But we're not. We're tracking a pandemic and we're tracking hospitalizations, and we want to care for the 650,000 lives in our community. And we are having a hard time doing that as the 3 health systems in our community right now. And people are scared. They won't come in, they delay treatment, and that's not good. So here's what our prediction is as of today, and it's where we're at. And we were tracking at that blue level, just so everybody understands. So the historical shows it tracking right on the money. We're within 10 admission days different in the prior 5 weeks, 10. That's how close the model was working. But it could be wrong, right? The storm could track to the north, to the red, and my hope for everybody is that it tracks to the south and goes down. So what's kept us going? So just a few key guiding principles. When we started this back in February, we started the planning of this, and we had no idea. And I'm not joking, we had literally no idea, because this was very new. This was very new for our nation. This is very new for the world. But we decided on a few core principles that I think apply to any employer. First was the safety of our team. That was of utmost importance. In fact, when we ended up stopping providing procedural care and stopping doing some imaging and cancer screenings and all that, and we didn't do it because we wanted to. We did it because we had to. We didn't have personal protective equipment at that time. We literally had none. We didn't have the protective devices that you see people wearing, that you'll see in the screens here in just a minute. We didn't have any of that. I mean, we had some, and we didn't know how to treat the illness either as well as we do now. And thankfully, that's coming faster. But we knew if we wanted to take care of everybody, we first had to take care of our team. And we've done that very, very effectively. We're less than 20 people that have acquired becoming positive in a healthcare setting from somebody else, a patient or their coworker. It's happened outside of the healthcare setting, and there are times where we're not very happy about that. But we got on that pretty quickly, and our quarantine rate amongst our employee staff is extremely low. It's because we taught and taught and taught the importance of the combination of procedures like masking, social distancing, hand washing, all of those things. It's not just one, it's the combination of everything. And we're fortunate that healthcare workers listened very well, and they saw it, and now they feel safe. And it's safe for people to come in to have their care provided for because of all the steps that all the healthcare systems have done. So please go in for care, and please tell your staff and family members to be seen for care. It's really, really important. Obviously, safety of the people we serve, and that shows itself all the time. Then we wanted to manage care delivery, which ultimately became coexisting with COVID-19, taking care of everybody. I already mentioned that. And I think one of the most critical things that we did is communication. I would say, besides obviously the safety of our team, we said from day one, we will be transparent with everybody. That's why I'm here. I have a reason to do this. I want to be transparent with you because I want you to trust us. And I think that's important to understand. So we developed lots of transparency around this, and we still do it today. And then the other thing that I'm very thankful and proud of is a lot of coordination with the other healthcare systems in our region, with public health, with our leaders in our county and city governments, and that still goes on all the time. So listening was really, really important. Our CEO, twice a week now, does something called Connect with Chris. Really, really important. It got everybody grounded on what's going on, and we myth-busted stuff all the time. She did. And we allowed people to ask questions. Really, really important. So we listen. So we listen to the front lines. We listen to our providers. When we started establishing all of these communication skills so that the 4,700 employees that we have across the 42 locations we have are all on the same page and know what we're doing. We listen to the employers, right? How do we safely open? How do we get businesses going? This is not all about healthcare delivery, by the way. We want healthcare businesses to thrive. We can't be sustained unless our employers are out there doing the things that our employers always do. We need schools open, right? We need all of that to work, to be a vibrant community, and that's really, really important. And we are continuously trying to do that. And the other thing is obviously learn. We've learned a lot about this disease. We've learned a lot about how we process things. And I would say we've learned more about how we can operationalize things as an organization faster than we've ever done before. So we've stood things up in a day or 2 days because everybody is on the same page and knows where we're headed. And I would argue that we've changed our workflows more times in the last 9 months than we have in the last 9 years because the teams respond. We respond. And we continually have significantly addressed the disease in different ways. So the length of stay in the beginning, if you had COVID and you were in the hospital, you were there for 20 days, 30 days, 40 days, and now it's down to 14 if you need an ICU stay. It's about 5 if you don't need an ICU stay. And what's happening is we're catching this a lot earlier and managing it outside of the hospital setting. If we hadn't learned that, I can't imagine what our hospitalizations would look like right now. Because we're catching this stuff a lot faster. Why? We have more testing. Because people know the signs and symptoms that are going on. So, and we're doing that as a community. So just a couple of slides. Our medical unit, which is generally where general medical patients fall, it's about 26 beds. That's become our COVID unit. That unit, by the way, before COVID was traditionally always full, right? That's the pneumonia patients, weak and dizzy patients, people that don't need a procedure end up on that unit. And we've had to put those patients, now there's not as many today, which is good, thankfully, but we've had to put those patients in other places in our hospital, and we created a COVID unit. Our emergency department and in our COVID unit, and you can see the devices, the PAPRs that are on some of the nurses on the right. They wear those every day, every shift. Every day, every shift, right? And there's more garb than that. We've had to put different walls on our ICU area. So you see on the left, that wall had to be created because we needed negative pressure rooms, isolation units. While we've had some, we need a lot more than we've had before. Our facilities people have been amazing, changing the pressures in all of our rooms, changing it one way and then reversing it and then changing it back. The middle is that ICU nurse, Jessica Landry, and she talked about the tubes and all of these different things. And look at all the bags hanging on that IV pole that are being administered to one patient. One patient. And those people in that garb every day, every shift, and hear her voice in that poem, "We got this." Not just with one patient, by the way. You know, in our ICU, there's 9 every day. Every day, it's full. And then on the right is a respiratory therapist. So I talked about what the disease does, and Jessica talked about breathe in, breathe out, breathing exercises. It's that basic. Respiratory therapists are like gold right now. You can't get enough of them. And yet I rode up in an elevator yesterday and just simply said, thank you. They are so humble, it's amazing. I'm just doing my job. They're the heroes. And it doesn't just affect the hospital. Think of all the care, which is 80% of, for us, outside of the hospital. Telehealth people. These are people that take the phone calls every day about, I want to get scheduled, I want to see this, I want to go here, I want to do this, I have this issue, should I go in? The call volume on those folks is overwhelming. We've actually had hospital physicians staffing that now at times. The people in the middle are clinics that have changed. We set up respiratory clinics for a while, and yet look at them. They're just doing their job. When we had to we changed our COVID unit, we shifted many of those patients to our 8th floor, which is our orthopedic unit. So when people have hip procedures or joint procedures, that's where they recover. On the far right is now where those orthopedic joint replacement patients recover. That's our therapy room. We've had to separate that and obviously create an isolation unit or create a medical unit on that 8th floor for overflow. And patients now recover from joint replacement surgery in our physical therapy area in temporary quarters. That's what's going on. And we're not the only ones. But we want to be transparent with you of what's going on. Standing up testing. This was actually at our site right next to the hospital now, our drive-through testing. We never had anything drive-through before. We never did. No health system did. And now we've moved it over to the formerly Sears Auto Center, and we've formed Bellin Fast Lane. And we use that automotive center so people can come in, the door can go down, they can get swabbed, and they can drive out. And yesterday I was over there, and they had scheduled 160 people, and they had seen over 300, and that was at 3 o'clock in the afternoon. And we've set up an alternative care site. We had the fortunate opportunity to acquire the skilled nursing facility on the Bellin campus, and that was done before the pandemic. And now that's set up and waiting for patients if we need it. It's an overflow facility, so we can keep care local. This is the trailer that we set up back in April. That was our idea. That's what we thought. And I showed you in the slide before, that's what it is today. We thought it was good. We were really excited. And then employers started having outbreaks, and we were able to stand up a multi-lane drive-through testing site at a local employer in 9 hours, full of IT, full of equipment, so that we could do this seamlessly so we can deliver results when? The next day. And almost every health system does the same thing, so we can take care of our community. So we've led, I've talked a lot about this, trying to connect with employers. We actually had a sitting secretary of the Health and Human Services, Alex Azar, come and visit Bellin because we started doing procedures faster than most did because we realized that we need to connect with the community. They weren't getting the care that they needed. We've now developed mental health moments done by one of our mental health therapists. I listen to them. They're powerful. They're humbling, and they center you when your mind goes the wrong way, and I will tell you, my mind goes the wrong way many, many times. It's hard, I get it. And then I talked about the communication. The communicating with the community, this is Dr. Paul Casey, he's an emergency room physician. And he comes every day, same thing. And he really got to become national. This is from MSNBC, he's done CNN, he's done lots of things. And trying to get the message out there of really what it's like and what's going on. And I think it's important to hear from those frontline folks in your community of what it's like. And then the things that we don't know, the implications of a pandemic. I can tell you Dr. Landrum, who's our infectious disease person, said told us yesterday on a medical branch call that there's a recovered COVID patient that ended up with a heart attack in the hospital because there's a lot of clotting issues for people post-COVID. We don't know the ramifications of that yet, right? We don't know the long-lasting effects of health status, not only on COVID-19 survivors. We know already preliminarily the impact of deferred care, but we also don't know all the mental health aspects. We have had our highest inpatient census at our psychiatric center than we've ever had. And it's younger people. Kids. We know we've had suicides in our community. Can't attribute it all to this, but I think there's definitely a link. So there's definitely going to be long-term implications that we're going to be learning about and evolving, and that's what we do. We as healthcare. And finally, there's some hope. There's a vaccine, 2 of them, just within the last couple of weeks that have been announced. I gave you a very detailed slide on the left. I don't pretend that you'll be able to read that. But our source comes from Vizient. You can go out there and see it. And obviously you're hearing a lot more about it in the media. On the right-hand side, I give you some key takeaways. What I rely upon is our infectious disease physician. The media tells you one thing. What I'm very much hopeful of is we're starting to get more detailed information now directly from the CDC and from the state. This is going to be a very challenging vaccine to distribute for a couple of reasons. One is we've never distributed this way before. Yes, we've distributed flu vaccine, and we have a process for that. But the level of dosing that needs to come, and then the process for distribution and who's going to get what and when are they going to get it, hasn't been all figured out yet. But the good news is we've got our applications out there, and it's going to be distributed to pharmacies and all kinds of people. The states will run the distribution process, and we haven't really understood the distribution methodology yet, but they're at least telling us that. And that gives us signs for hope that it's going to come soon. Our best prediction right now is right after the end of December. And we do expect right now, our best guess is we'll see both vaccines, the Moderna and the Pfizer. Both of them, unfortunately, require 2 doses. And they have to be given within a 21 or 28-day period of time. So people are going to have to come in twice for the vaccine. That's important to understand. The other challenge with the Pfizer vaccine is it needs to be stored in very, very cold temperatures. So cold that we don't have freezers that can handle that, and no healthcare system generally does. So I'm thankful that we're in a meatpacking market. I think that will be helpful, but we're still working through that. But I just want people to understand that there will be challenges with logistics and distribution. Fortunately, the Moderna one doesn't require that cold of storage, but there's going to be processes. And again, as I mentioned, the drawback are 2 doses. Now, a lot of people are asking, is it safe? You know, what we will tell you is we're not going to require it for our employees day one. We're pragmatic and realistic about it. But what I will tell you, and this will be an emergency release by the FDA, but the efficacy is been reported as very high. And generally, what the infectious disease providers will tell you about vaccines is the follow-up process during a trial phase is about 2 months. And that is sufficient enough to catch about 99% of any issues that would come as a result of a vaccination. And that's the data that we have. So we're very much looking forward to that as a component to controlling this. And with that, I will stop and ask for questions.
And I do have some that have come in through Q&A session.
You go ahead and get them. You want?
So
got it.
I have the first question here. The COVID testing turnaround times seems to vary greatly. Why? Great question. It really, first off, most of the local health systems have very, very limited access to testing, resulting tests on site. Okay, so what happens is the health systems end up sending out their tests to another laboratory. And depending on who that health systems use for its laboratory, depends on how, that's really the variable that happens. We've been fortunate for the most part that our turnaround times at Bellin are a day. If you come in, especially before noon, the likelihood that you're gonna get your test result back the very next day is very, very high. And then the other component to that is if the testing result is electronic. So sometimes those results are actually faxed back to the hospital system and they have to hand enter that into your medical record. We've fixed a lot of that because the resulting laboratory actually electronically, or they load that data in, and as soon as that data is loaded, the patient will get the result just like when we get our result. That's the big reason why turnaround times are so different. Each health system will vary depending on who's actually performing the test itself. And then the community testing sites like out at GB, depends, they obviously have the antigen test, and an antigen test is not as reliable as something called a PCR test. So now I know when you go out to GWGB, they'll give you the antigen swab. And the false positive rate is much higher. And if you get a false positive rate, what they want you to do is then get in the other line, which is the PCR test. The PCR test is that's a much more accurate test, but it takes longer to get your result, and they usually send that test out. So that's why.
Okay, next question then, Jim. Is there a statistic of those who die with COVID versus those who die due to COVID? Everyone has a story of people who died of something other than COVID, but it is coded as COVID.
Yeah, I've heard that question many times. So can the audience hear that question?
They can hear John repeat.
Okay,
Yes.
thank you. So this started right in the beginning, and we just can't get away from it. Health systems, and I'm gonna share this in the appendix. Health systems do get an add-on payment for patients that present with COVID or that it's part of the condition of why they're admitted. And we get a 20% add-on payment for a diagnosis that includes COVID. You have to understand, for the most part, when somebody is admitted into the hospital for a diagnosis, if it's not procedural, they typically have multiple conditions, such as chronic heart failure, diabetes. Those are all conditions, just like COVID is a condition. COVID typically accelerates another illness, is really what happens. There's generally people that are admitted to the hospital aren't just admitted just with one condition. COVID exacerbates someone's condition, is typically what happens. When we bill for services, you are allowed to include multiple conditions on a bill, including COVID. Obviously, COVID results in isolation. Many times, 1 in 3 people have to have ICU. And there's more intense services. I showed you pictures of it with that. As a result, The federal government has recognized it, and they give us a 20% bump in our payment for that. This is why people are skeptical of that. I can tell you unequivocally, I have looked at that time and time again, and if there's a positive test on a patient, it will go on as a diagnosis because that tells us how we need to manage that condition. They go into isolation, right? Everybody gowns up, right? We have to think about their care going forward, and we have to monitor them much, much closer. But we don't make money on that at all. And this slide illustrates it. The blue is the direct cost of someone with COVID. The red is the direct cost of a similar type patient. Think of a pneumonia patient that isn't positive. That's our cost with someone like that. This is our payment, all right? So the blue acknowledges the 20% add-on. These are real patients, by the way. We accumulated that because our finance committee asked the same exact question. So yes, we do get an additional bump in payment, which is the blue when they have a diagnosis that includes COVID, and the red is when they don't have that diagnosis, but a very similar condition and a somewhat similar treatment treatment process. The one thing that I would say is the therapeutics associated with COVID. Remdesivir is a great example of that. The drug cost for that alone for a 5-treatment episode is $32,000. All right? Yeah. So here's the net of all of that. Most of these patients, yes, are older, so they're typically Medicare type patients, and this is the profit analysis per patient when somebody is admitted with COVID. Okay, obviously in the commercial side, it's better, but generally their length of stay is lower. But in total, the majority of patients are Medicare related. So I did not set John up with that question, but I thought somebody may ask that, which is why I included this in the appendix for you.
Thank you, Jim. Couple more questions. For those who have had COVID, I understand there's an assumed 90 days of immunity. Can you talk more about this? How accurate, confident is the health system about 90 days being an accurate number? Do you see any risk caused by the assumed immunity?
Yeah, it's a great question. It's another example of what we're learning, right? In the beginning, most viruses, and COVID-19 is a virus, just like any other virus, there's an assumed that you can't get it again. And generally, there's been singular cases for the most part that have said, hey, they've been reinfected. The other thing is that viruses mutate. And so we don't know a lot about the mutations yet, as an example. So there is a general assumption that you're okay for 90 days because of the antibodies. There's also some hope that has been identified in research, is that yes, your antibody decreases over time, but what they've also studied is then when you're exposed again, your antibody, your viral level to fight off that actually grows as well. So the reality to your question, John, we don't exactly know yet. I don't think it's safe to assume that you're protected. We generally believe that you won't reacquire it. However, we don't know enough because a virus does mutate.
Thank you. Next question. Are there different strains of COVID since some people are asymptomatic while others are dying? What causes the wide variance of symptoms other than unrelated underlying health issues?
Right, so there are many different strains of COVID. And this particular strain obviously didn't exist until they discovered it in China. And this strain really obviously is dramatically different than the previous strains of COVID. So we don't exactly know why someone who is asymptomatic or symptomatic has that type of result. And we don't really know why COVID attacks someone differently than others. It's the reality of our human body.
Next question. Experts predict more pandemics in the future. What, if anything, would Bellin do differently and how will it remain prepared for such of an event if it occurs?
What would we do differently? Obviously, I don't think our nation was prepared. It's clear evidence of that. We don't have a singular reporting system. States kind of have done their own things. The resource that I showed you, that Wisconsin Hospital Association database, that didn't exist. So I think as a nation, we've learned a lot. Obviously, I think some of the guiding principles that we put into place in the beginning are foundational. I'm so thankful that all the health systems in our community said, we are speaking with one voice, as an example to that. So we definitely have learned things, and I think the guiding principles will be helpful, and obviously changing our nation in terms of delivery of access to emergency medical equipment, personal protective equipment. They reduced the national stockpiles several years ago because they didn't feel the need for it. And we definitely felt that as a nation, and definitely in our community in the beginning. It's why we stopped doing procedures. So we didn't have access to any, there wasn't any stockpiles that were there. That's the reality behind it. So obviously those things are gonna change because there is an expectation that another pandemic will happen again.
Couple more questions. What are the short-term and long-term financial effects of this pandemic on the healthcare system?
Yeah, so in the short-term effect was significant. I showed you our revenue. There were basically 3 months where, we were losing $15 million a month. We're not that big of a health system, and everybody's in the same boat. It's just relative based off of size. So they were very significant. Obviously, we got some help from the federal government in terms of the CARES Act money. We're way underwater when it compares to that. We've received $14 million in CARES Act money as an example. The long-term impacts are very concerning, I would say, for healthcare, mainly because of the slide that I showed you, which is this. We don't know. I think we're going to learn a lot. I don't think you're going to see, obviously we learned a lot about video visits and how people love video visits and the convenience of that as an example. I hope to think that you'll see less large facilities, and you'll see us using technology in different ways and using different ways to connect with the people that we serve. We definitely have changed our long-term financial planning. There's no question about it.
We got time for one more, Jim. What can we do to convince others to take this seriously? Unfortunately, facts don't seem to be working.
Yeah, that's why I showed you all the data that I did today. I think we're best as a community and as a state to hold each other accountable. I think that's my personal opinion, is that's what works the best. Not to shame people, but to build awareness and educate and try not to mandate things, because mandate just creates this wall. And it's why I showed you what I showed you today. I was certainly skeptical in the beginning. I'm certainly not skeptical now. And what I'm worried about is all of you. You are the backbone and fabric to our community by meaningfully, gainfully employing people. That's why our area is thriving so well. We're a diversified economy. We're a very well diversified economy. We have good school systems, right? I've been interviewing more physicians now from major metropolitan areas than ever before. It's amazing, and you hear their stories, right? But if we're not vibrant because we have a sustainable economy, we're in big trouble. That's the reality by this. So I don't think we can just think of the healthcare systems selfishly. Do I want to lower hospitalizations? Yeah, but I want to lower hospitalizations so we can take care of others and not delay people's care, because it just stacks up, right? Mammograms need to be done. Cancer screenings need to be done, right? If we have to stop, Freighter announced today that they're stopping elective procedures. Advocate Aurora announced a couple days ago, they're stopping elective procedures. That will just stack up, and then people will get disenfranchised. And guess what? Many of those people are your workers. So we have to make everybody realize that we work as a community together. It's not this, I hope my presentation was meant, people took it from that it's about our community and that we have to help each other.